This is the all recorded sessions. We have Dr. Lamia, Dr. John, and Dr. Ahmed Damati, Dr. Samir Rafla, and very eminent attendees from all over Africa. Dr. Rania Samir is going to share with us a case which was, she was the operator with me and Dr. Muhammad Said at Shifa Hospital. Dr. Rania is a professor of cardiology, consultant of electrophysiology at Ain Shams University, and I call her the princess of EP.
Thank you, Dr. Amirvat, and you are the queen of EP, the EP mother, as we call you. Thank you for the great presentation, and hopefully it will be an interesting case. Okay. Our patient is a male patient who has he's age 60 years of age. He's not diabetic or hypertensive. He had a mitral valve replacement with mechanical valve prosthesis back in 2019. I don't know actually why was it for mitral regurg or mitral stenosis. He didn't state it. He had a previous ablation of CTI-dependent atrial flutter back in Libya in 2021. And excuse me? Okay.
And you mute the microphone.
Okay. And he had ahead. Later on,
after Libyan patient.
He was a Libyan, yes. He was a Libyan patient, and he had an ablation of CTI-dependent atrial flutter back in Libya in 2021. But after this ablation, he had a history of recurrent attacks of persistent atrial fibrillation. The last one was terminated with DC shock after transesophageal echo. His echo showed mild paravalvular leakage, and I think we had the consultation of an eminent congenital cardiologist, and he said, no. He had a mild paravalvular leakage. His echo showed an ejection fraction of 58%, and his left atrium was dilated with 50 millimeter. And this is his resting ECG. As we can see, he has a resting heart rate of around maybe 65 or something. He had a right bundle branch block and upper normal PR interval. His ECG of persistent atrial fibrillation was not available. I couldn't have it, but I think Dr. Mervat saw it, the ECG of atrial fibrillation. And I think all his ECG after his atrial flutter ablation was atrial fibrillation. There was no ECG documentation of atrial flutter. So the plan was to do catheter ablation of atrial fibrillation, basically pulmonary vein isolation, and we're going to do a voltage map to see if he has a low voltage areas, and with putting in mind we might have other ablation targets depending on the substrate mapping that we're going to do. And of course, we're going to, after PVI isolation, we're going to check for complete CTI conduction block, to make sure that he doesn't have a residual conduction block across the previous ablation of this the cavo-tricuspid isthmus. We did our, I think we went in while the patient was in therapeutic, on therapeutic dose of anticoagulation. His INR, I think we went with INR 2 or 2.5, and we did the procedure under general anesthesia, and we did only a single transeptal, as we can see here in this cine images. This is the cine images or fluoroscopic images of our transeptal puncture in LAO view. We usually do the transeptal puncture with the use of guiding catheter, decapolar catheter in the coronary sinus to mark the mitral annulus, and a quadripolar catheter to mark the position of the Hess. And we usually use a fluoroscopic guidance in LAO view and REO view to guide our transeptal puncture. In this patient, we opted to do only a single transeptal puncture, and we did it under fluoroscopic guidance and TE guidance. And here we can see after we went into the left atrium with the non-deflectable sheath and the Smart Touch ablation catheter, and we removed and we can see the prosthetic valve is a bileaflet mechanical prosthesis. And here the penta-array, the multi-electrode catheter, it's a penta-array that we used for mapping of the left atrium. And during our, then we decided to do both an anatomical and a voltage map because this is a patient who had a valvular heart disease and he has a prosthetic valve. So we anticipated an involvement of the substrate of the left atrium. So we decided to do a left atrial voltage map created by the penta-ray catheter. And in patients with prosthetic valves, we usually tend to use fluoro more in order not to get the multi-electrode catheter or the mapping catheter into the prosthetic valve. And also we used a lot of RAO to see the orientation of the catheter in relation to the prosthetic valve. And as we can see here, this is the voltage map of the left atrium. We know that the cutoff values for normal voltage in left atrium is above 0.5 millivolt. And we can see here that the left atrium has a normal voltage. There is decreased voltages in the distal pulmonary veins, and it's expected. But still there is normal voltage at the ostium and the proximal parts of the pulmonary veins and the carina. And then during creation of the map, the patient had episodes of sinus bradycardia. So we did most of the map during pacing. We did coronary sinus pacing, and we did the pulmonary vein isolation, as we can see here, using the close protocol. The close protocol with a target with an energy used 50 watt. We use 50 watts anteriorly and posteriorly with a target ablation index 550 anteriorly and to the roof and 450 posteriorly at the posterior wall and the floor. And we don't usually do carinal lesions unless we have, after a complete isolation of the vein, if we have a recording inside or a AGM's recording within the carina, we usually do carinal lesions. And we usually do an interlesional distance of less than 5 millimeter this anteriorly and posteriorly. And of course, at the end of the pulmonary vein isolation, we ensured the complete isolation by entrance and exit block. But during the procedure of the pulmonary vein isolation, we noticed that the patient goes spontaneously into atypical atrial flutter, and it was rather stable with a cycle length of around 400 milliseconds, as we can see here in this intracardiac recording obtained from the coronary sinus catheter that is depicted in green. And we can see here that the patient had an atrial tachycardia or atrial arrhythmia with one-to-one conduction, and later on we can see that it has variable AV conduction also. And it spontaneously terminated also all through the procedure. So we decided to do the pulmonary vein isolation first, and then we tackled the atrial flutter. We completed as we can see here in these images, in AP view and RAO view and LA view, we can see that we did complete pulmonary vein isolation, and we ensured, as I told you before, the pulmonary vein isolation using entrance and exit block. And then after we completed the pulmonary vein isolation, we started induction of the atrial flutter. The atrial flutter was easily inducible spontaneously and by atrial programmed electrical stimulation from the coronary sinus. We can see here that we started pacing from the distal coronary sinus, and we can easily induce a stable atrial flutter with a stable cycle length of 490 milliseconds. It's quite slow atrial flutter. Then we decided to map this atypical atrial flutter. At this point, we didn't know, is it coming from the left atrium or the right atrium? And we have a certain protocol we do during mapping of any atypical atrial flutter. We usually do it under general anesthesia using multi-electrode mapping catheter. And this patient, we used the penta-ray catheter to do the mapping. The mapping first, before we do the mapping, whatever we're going to do an activation map, we have to localize the chamber of interest. Where this re-entry circuit, is it in the right atrium or the left atrium? So we decided to do a targeted entrainment from different sites in the right atrium and left atrium. This is a general rule, and we measure the resulting PPI. In right atrium, we usually, in any atypical atrial flutter, we start with entrainment from the CTI, kyphotrichosisthmus, proximal coronary sinus, right atrial appendage, lateral right atrium, interatrial septum, and sometimes also the posterior right atrial wall. In the left atrium, we usually do multiple entrainment from the distal coronary sinus, left atrial appendage, posterior wall, roof, and septum. And we measure the corresponding PPI, and we see where's the shortest PPI, and this can localize the re-entry circuit. Is it in the right atrium or the left atrium? After we localize the re-entry circuit in which chamber, we do an activation map. And we usually do this activation map with the guidance of a 3D mapping system and a multi-electrode catheter like the Pentarray or the HGRID to identify the re-entry circuit or circuits. And then finally, we localize the ablation targets based on finding interesting EGMs during the activation map and doing targeted entrainment. We usually limit the entrainment. We don't do too much entrainment because too much entrainment during atypical atrial flutter can change your re-entry circuit and change the cycle length or change your atrial flutter to another atrial flutter who can stop the tachycardia altogether, and you cannot reinduce it. So we limit the entrainment as much as possible to interest in sites with interest in EGMs in order not to stop the tachycardia or change the tachycardia. In our patient, we did entrainment from different sides of the left atrium because the patient has a mitral valve replacement. So we actually entrainment from the left atrium and the right atrium. Entrainment from the left side, we did from the left atrial appendage, posterior left atrial wall, and distal coronary sinus, as we can see here. If we can see in this fluoroscopic images, these are the catheters we used during atrial flutter mapping. Coronary sinus, decapolar catheter in the coronary sinus, the smart touch catheter, ablation catheter in the left atrium. Then we withdrew it in the right atrium, and a quadripolar catheter that was in the HIS, we put it in the lateral right atrial wall. And we started entrainment from the left atrium first, from the sites I said before, and this intra-AGM shows entrainment from actually the left atrial appendage. And we can see here, this is the recording from the coronary sinus during the atrial flutter. And this is the HIS recording or the recording from the quadripolar catheter in the lateral right atrium. And as we can see here, that the tachycardia was actually entrained at 480 milliseconds, which was the pacing cycle length. And then after stoppage of the tachycardia, we measured the post-pacing interval, which is the PPI, and it was very long. It was around 100 milliseconds longer than the actual, or 80 milliseconds longer than the actual tachycardia cycle length, which was around 500. So, and we repeated this entrainment from, as I said before, from different sides of left atrium, and all the PPIs were very long. So we decided this is not a left atrium, most probably not a left atrial flutter. We started entrainment from the right atrium. As we can see here, we entrained from the proximal coronary sinus, from the CTI, from the lateral right atrium, and the shortest PPI, as we can see here, from the lateral right atrium. We entrained from the quadripolar catheter that is placed in the right atrium, and we ensured that we are entraining. We can see that the AA interval during pacing was for 70 milliseconds, and the PPI after stoppage of the pacing, the PPI after stoppage, the pacing measured around 520 milliseconds, and the tachycardia was almost, as I said before, 500 milliseconds. This means that we have a difference in the PPI to tachycardia cycle only 20 milliseconds. This makes sure that the lateral right atrium is a part of the re-entry circuit, and it's definitely it's a right atrial circuit. So we decided to do an activation map using the Pentarray and a right atrial activation map and voltage map from the right atrium. And this is the map on the left is the activation map, and the map on the right is the voltage map. And as we can see here, if we look at the this bar, the color-coded bar, we can see that we almost mapped the the majority, or more than 95% of the tachycardia cycle length. Okay, and if we look at the voltage map, the voltage map, this tries to localize the areas of low voltage areas or the scar tissue inside the atrium. And in the in atria, the normal voltage, as I said before, takes the violet color, and it's the any voltages above 0.5 millivolt. Any voltage less than 0.1. Someone is writing on my presentation.
ازاي مش عارف.
Someone is writing on my presentation. I don't know how. I don't know how.
ده ده ايه اي بقى ده.
I don't know. So this is the right atrium, and any voltage less than 0.1 millivolt, this is heavy scar and takes the color red. And in any voltage in between is low voltage areas, but it's not a dense scar. And as we can see here, this is the right atrium in aerial view. This is the SVC, the IVC, the tricust annulus. This is the anterolateral wall. Okay, and we can see here, this is a low voltage area or scar tissue spanning the whole length of the posterior part or the most lateral part of the anterolateral wall. Okay, and if we look at the activation or the activation map, the earliest activation takes the color red, as we know, and the latest activation takes the color violet. And you can see here, and I'll show you the propagation map later on, that the activation moves around the SVC in a circular manner. So we have one re-entry circuit that moves around the SVC and traversing the scar tissue. So this means that we have a gap within the scar tissue. And if we look at, this is the propagation map after creating an extended early meets late algorithm. The extended early meets late, this is an algorithm that built in the 3D mapping system that creates white lines across areas that is suspected or presumed to have lines of block. And it usually measures that any two adjacent points, if the difference between them more than the lower limit you set for the extended early meets late, this means it will depict this area as area of double potential or area of block, and it and creates a white line, as we can see here in this map. And this is the propagation map. I will repeat it again. I'll start it from the beginning. I'll wait till it starts from the beginning. Okay, we'll start from the beginning. This is, we can see that activation moves from inside the scar, a gap through the scar, and rotates posteriorly across the posterior wall and abruptly stops. And then activation moves into the septum, and there is another line of block. Okay, and the activation across the septum goes from the coronary sinus into the appendage and the anterior wall, and then circulates again. So we have a circuit, a single circuit moves around the SVC, and I believe that there is also participation of the left atrium passive activation through the Bachmann bundle here. It goes into the left atrium and then activates the septum through the proximal coronary sinus, and then activates the rest of the right atrium. That's why the cycle length of the atrial flutter is too long. And we can see here, we have a scar tissue here, and might be a small low voltage area at the septum. So what explains the scar tissue? And here also, sorry, this is also the activation map without the extended early meets late. The sequence of activation moves the same way. We have the activation starts here and moves through this scar and rotates around the SVC between it and the tricust annulus, and it moves around, as we can see here. Okay, So what explains the huge scar in the lateral right atrium? We have to understand the patient has a mitral valve replacement, and sometimes the surgical axis during mitral valve replacement differs. We usually have 3 different axes for a mitral valve replacement. 2 of them utilizes the lateral wall of the right atrium. The first approach is the left atrial approach, and they do the surgical incision in the left atrium, vertical incision, left atrium between the interatrial.
انت جمعة بجمعة اي كنا نعطيك جمعة 100 وجمعة لا مش نعمل هكاك جمعة بجمعة ريقل تعمل ريقل
Please mute yourself, everyone. Please,
ريقل
audience, my audience, my nice audience, mute yourself. Go ahead, Rania.
You are muted, Rania. Please unmute
Oh,
Rania.
sorry. Okay, I made a mistake. Sorry. Rania
I'll
Samir.
unmute myself. Okay. So
Yes, you
the
can.
vertical incision is usually a vertical incision. It's a left atrial axis, and of course, it's in the left atrium, anterior to right, between the interatrial septum and right pulmonary veins. The second axis is utilized the right atrium, and it's the vertical incision that extends through the anterior wall and goes superior transseptal and then to the left atrial dome. So it's a very large incision that takes the whole lateral wall of the right atrium, the superior transseptal, and then the left atrial dome. The third incision, and I think this is what happened in our patient, it's 2 incisions. One, a lateral right atrial incision through the lateral wall, and it's usually parallel to the AV groove, the tricuspid annulus of the AV groove, and then the other incision is is a transseptal incision or to gain transseptal axis, and it's usually done posterior to the fossa ovalis, in the junction between the septum and the posterior right atrial wall. And I believe this is what was done in our patient. So we are left with a huge lateral right atrial scar and a small transseptal scar. And we can see that the re-entry circuit was in the right atrium. And when we mapped close to the gap in the scar tissue, we can identify low voltage area, the pink dot, low voltage area that was bounded here and here with double potential here and double potential here, and there was a small gap in the scar tissue that we could record fractionation, very good fractionation. And when we went there and started ablation at this point, from the first RF application, we can terminate a very stable atrial flutter all through the procedure. Then we continued our ablation. We consolidated the lesions more to close the whole gap between the gap in the scar, to close it. And here our ablation lesions closing the gap in the scar. And then after this, we did programmed electrical stimulation and pacing from the atrium, from different sides of the atrium, trying to induce the tachycardia. After we did our ablation, there was no inducibility of any type of atrial flutter, even with drug provocation. And before going out, we confirmed that the patient has a complete bidirectional isthmus block across his the previous ablation line. There was no post-procedure complication. The follow-up after 3 months, there was no recurrence of any arrhythmias. The take-home message is if atrial fibrillation catheter ablation in patients with valve prosthesis is feasible, safe, and effective with proper selection of patients and pre-procedural planning. Patients with mitral valve replacement can develop right atrial atypical atrial flutter due to atriotomy scars in the right atrium. We have to revise their approach, their surgical approach. Thorough activation mapping using multi-electrode catheter with targeted entrainment mapping are the key tools for successful ablation in atrial flutter. Thank you.
Thank you very much, Dr. Rania. This is a very interesting case. I see that Dr. Ashley is with us. He is the chief of the advanced course. Dr. Ashley Shin.
Prof, thanks very much. Yeah, that was a very good case. I mean, I've always, in my experience, I haven't done a lot of PVI with my mechanical mitral valve replacements. I know in some centers they consider it to be sort of a relative contraindication. So just some tips and tricks about how to navigate the atrium with a mechanical valve, just in terms of, I see you do one transeptal puncture, so minimizing the catheters going across. And then how do you just keep the catheter aimed posteriorly in the atrium and try to avoid going in anterior?
Avoid to get in anteriorly. The well, it's not a relative contraindication anymore to do AFib ablation in valve replacement. Actually, there are several publications that say that it's safe and feasible, but you have to select your patients very carefully to benefit from the ablation. You cannot go with a patient who had a mitral valve replacement and a huge left atrium, 70 millimeter or something. He will not benefit from the ablation, and PVI will be consequential. In patients with mitral valve replacement, first you have to go on therapeutic INR. You have to go with the patient on his oral anticoagulation. Maybe you can decrease the dose, but he has to be on a therapeutic INR. We tended to do a single transeptal puncture to minimize the punctures across the septum, multiple, and we did it under transesophageal echo and fluoro guidance to minimize complications, and also to try to maneuver the catheters away from the mitral valve. We tend to use more fluoro than usual in normal cases, and we use RAO views. RAO views will show you the catheter, the position of the catheter in relation to the valve. So you always tend to stay away from the valve. That's it.
Yeah. No, thanks very much.
Look.
I have a question to you, Dr. Ashley. Do you think in Africa with rheumatic heart, do you think that we should push for ablation of atrial fibrillation in presence in rheumatic heart disease with left atrial dilatation and fibrosis? Do you think this should be our mission?
My personal opinion is that I think it's a different disease entity than your pulmonary vein trigger driven atrial fibrillation. I know that the surgical literature for rheumatic atrial fibrillation is very promising in terms of recurrence, and it's quite effective in the treatment of atrial fibrillation. But just from the experience that I've seen, here in Cape Town, our patients we often see patients when they've got chronic AF, LA sizes, 6-7 centimeters, and AF for long standing. I think clearly for those patients, we would recommend a rate control strategy. I think there is a role for patients, maybe who present early with paroxysmal AF and with mitral stenosis and mitral valve disease. And in those patients, I've asked the surgeons to do a surgical pulmonary vein isolation at the time of their valve replacement. I don't have experience with doing, I know that there's some experienced centers I think in India that are doing pulmonary vein isolation for atrial fibrillation due to rheumatic heart disease, and with reasonable success rates. I mean, it's still 50-60% success rates. So I think there are some centers doing that, but I don't have experience with rheumatic AF. I think our surgeons are doing quite a lot of AF ablation at the time of mechanical mitral valve or biological mitral valve replacement. But we tend to choose patients who are paroxysmal or short-standing persistent, rather than the patients who have got big atria, long-standing atrial fibrillation.
We have a question, Rania, from the audience in the chat about phrenic nerve stimulation when you ablate in the right atrium. Do you test for phrenic nerve?
If you are, excuse me, someone, can you mute?
Yes, I did.
Whenever, I think, of course, if you are ablating from the lateral right atrium, especially higher up in the lateral right atrium, whenever you choose your ablation target and you find it in the lateral right atrium and it's high up, before doing your RF application, you have to stimulate the phrenic nerve first to make sure that you're not on the phrenic nerve, because if you ablate there, you might injure the phrenic nerve. So you have to do phrenic nerve stimulation first before doing your RF ablation in high lateral right atrium.
Dr. Rania, Dr. Amervat, how are you? It's Hani Samir.
Dr. Hani.
Hi, Hani.
Thank you very much, Dr. Rania, for the lovely presentation, as usual. It's actually a very good example of the important message of excluding the presence of multiple tachyarrhythmias in our patients during the procedures. In this case, you were lucky to have the arrhythmia and the flutter expressed during the procedure. Would you incorporate into your standard ablation technique for AF or other is to do a full electrophysiology study for patients, or you selected high-risk patient like this one if he has an operation before and a mitral replacement before?
Well, I don't think in a patient like this who had a previous surgery before, an atriotomy scar before, I wouldn't tempt myself to do this unless he has an ECG or even or at least a Holter recording or even a smartwatch recording of an atrial flutter before an induced. Because in the presence of a scar, even if the patient didn't have any documented tachycardia, you have the risk to induce a tachycardia that is not clinical, non-clinical. So I think I wouldn't do this unless the patient had some sort of a documentation of an atrial flutter. And I would like to have the opinion of Dr. Mervet in this. That's my opinion. I wouldn't do it.
In this patient in particular, yes, because he had the documented atrial flutter procedure done before. So, and
in this patient in particular, okay, we had it in our plan to do the PVI and then to check the CTI and maybe induce atrial flutter in him. But in other patients, no, I wouldn't be tempted.
Other patients not traumatic like yesterday's case, Rania. The patient, he was all documented atrial fibrillation because he's 35 years old. He's coming for AF ablation. We started with EP study even under general anesthesia, but
for SVT.
Yes, at the end of the study, although he had only atrial fibrillation, but after isolating the pulmonary veins while we were stimulating the right atrium for something during the procedure, he developed AV nodal enteral tachycardia, and it was incessant, and that was under general anesthesia. So, yani, EP study is okay but this is for in some cases like young patients going AF ablation. We do this in order to exclude any associated arrhythmia. Okay, now we finished the first half of the presentation. Dr. Rania Samir, you are the moderator. Rania Samir.
Yes, thank you very much, Professor.
You are responsible with Dr. Damati is with you for the second session. Thank you, Rania. Thank you, everybody.
I have to be excused because we have iftar.
Thank
you very much, Dr. Halan. Well, it's a great honor to be with you.